So when we work with people, we really want to figure out what are the mechanisms, what are the specific things about change. I don't want it to be too general. Okay. So my research example, I'll tell you a little bit about the work we've done, and it really has been in real world settings. And we've done a number of clinical trials, we've done a number of studies with SAMHSA, a number of demonstration grants, a number of projects where we're working on dissemination. Sometimes we do it well, sometimes we don't do it great, also perfectly, but we're working at it and we're working hard at it. So some of our examples are community health clinics, some of our studies we've done in jails. Harris County has the 4th largest jail in the country. Harris County itself is the 4th largest hospital district. We do a lot of work in community clinics and in hospital trauma units. You're going to be next 30 minutes, should be done. So this is just, I won't read this slide, but these are some of our clinical trials that we've done. Most of them are clinical trials and our funding sources. Here in Houston, when I was here, again, we worked with Harris County Jail. We worked with Baylor, the Baylor Teen Clinics, in a couple of areas. One is Acres Home, people say it differently, which has one of the highest chlamydia and gonorrhea rates for teenage girls, one of the highest rates in the country. So we were using some brief motivational interventions in those clinics with some physicians at Baylor. Transtheoretical model group therapy for cocaine. We have a treatment manual that Kathy's going to talk about in just a minute. We did one of the original studies for SAMHSA, the expert studies, again, here in Harris County Hospital District. In fact, we helped develop that brief intervention and brief treatment manual is based on our work that Kathy's going to talk about. Robert Wood Johnson, we've had some funding from NIAAA to analyze our tapes and see how motivational really works when it works well. Currently, we have a NIDA-funded research project that is at Brackenridge Hospital in Austin, looking at the efficacy of treatment for drug use or brief intervention for drug use among people who are in the trauma unit. So what research seems to be showing is that if your neighbor goes out and gets in a car wreck or gets shot or is drunk on 6th Street and ends up in the trauma unit at Brackenridge Hospital, if someone goes in and talks with them for a few minutes about their injury and uses some motivational interviewing and does a brief intervention, there's about a 47% reduction in injury and return visits to the trauma unit or the emergency department. And who is best to do that? Is it the surgeon? Is it the nurse? Well, I contend, of course, that it is the social worker, and that's who's oftentimes embedded in those systems. And my contention is that it's the social worker, doesn't need to be doing just the discharge planning. That as we develop these healthcare teams, it's the social workers who are going to be integral parts of those teams. And can we help our students be ready for that? That's a whole other side conversation, but. So NIDA and other people said, well, we know that this seems to work for alcohol, but does it work for drugs? When you talk with someone about drugs, well, that, the case gets much more complicated when that happens because, there's comorbidity, there's what drug is, if they're not dependent on prescription painkillers before that, once they go into the hospital setting, oftentimes that becomes the case. So it's kind of complicated. So that's our current study. So all of that is just this is Carlos Brown, who's the head trauma surgeon. I just like his cap. He's one of the investigators. This is just our study design, which I'll spend a lot of time on. So one example that has been an evidence-based intervention, or is an evidence-based intervention, is based on Project Choices. Choices began a number of years ago. It was funded by the CDC, and the CDC put out a call for proposals asking for studies that would look at, well, first they wanted to know, where do we find women at high risk for alcohol-exposed pregnancies? So women at risk, they wanted to study women between the ages of 18 and 44, not women who were alcohol dependent, but women who were drinking at risk levels, maybe like college students might be doing, or maybe like, me and you, not really, but potential. Well, not me because of the age thing, but young, where do we find young women who may be at risk for having babies who have fetal alcohol spectrum disorder or who are exposed to alcohol. So here in Houston, we worked with, again, the jail and several substance abuse treatment centers here in Houston. Mark and Linda Savell were wonderful alcohol researchers. If you don't know their story, I'll tell you if you're interested. Amazing. They're the first people who did harm reduction and ran into lots of trouble doing that kind of research because it was not popular at the time. They were in Florida and some primary care clinics and a media recruited sample, and Karen Ingersoll and Mary Netherland, who were in Virginia. So we had this multi-site team of PIs with the CDC at the helm, which is sometimes wonderful and sometimes a little hard, but we had a great program officer. Alcohol use, as we know, prior to pregnancy is a very strong predictor of alcohol use during pregnancy. So we wanted to get women in this preconception phase. Could we find these women? Where were the settings where these women were most likely to be at risk? And could we do something to intervene with these women? Again, so they're not pregnant. Because oftentimes people don't know they're pregnant. Women don't know they're pregnant until about at least 6 to 8 weeks after they get pregnant. And by then, oftentimes the baby is already exposed to alcohol. Most efforts to prevent the effects of alcohol-exposed pregnancy intervene with women once they're pregnant. Okay. Just briefly, it's one of the most preventable causes of all kinds of problems, mental retardation and other causes. There's no amount of alcohol that is safe that we know of during pregnancy, so the recommendation to women is to not drink. FASD can be everything from attention deficit disorder, behavior problems in a kid whose mom was drinking when she was pregnant, and perhaps even small amounts of alcohol, through full-blown facial dysmorphia and the effects of fetal alcohol syndrome. And those effects, of course, last a lifetime, and FASD is 100% preventable. So we were looking at what we call preconceptional women with risky drinking patterns. And so that could be anything over 4 drinks or more a day, or more than 7 in a week, which is the NIAAA guidelines for risk drinking. And so these were women, these were not women presenting for treatment. These are opportunistic settings where the women sort of happen to be. And we wanted to see if we could reduce their drinking to the low risk levels, so if they should become pregnant, the drinking would not be a problem for them, and it would be easier for them to stop drinking. And we wanted them to get contraception if they were going to continue to drink and be at risk. So we set up systems at the Harris County Jail where they could meet with a treatment provider to reduce their risk. So the CDC did it right this time. It was a long 16 years of this research study, different phases of this research study, which is continuing on even now. First, they did an epidemiology survey to find out where are the risk settings. Is it primary care? Are they the jails? Is it OB-GYN clinics, WIC clinics? Where do we find these women who might be at risk? What are the characteristics associated with these women being at risk? Obviously looking at income levels and comorbid disorders, other things. On these slides you can see we've published a number of papers on this. Then we did a feasibility study. Can we really do this? Can we go into jails? Can we work with these women? Will they come back after they get out? We worked with them 2 weeks prior to their release from jail, and then we followed them for 2 more sessions. We worked in substance abuse treatment clinics. Could we really do that there? Could we do it in primary care? How did that work? So we tested it. We developed a manual, incorporated some motivational interviews, incorporated the behavioral and experiential processes of change that I was just talking about, and then we tested the feasibility of that. We published that in pediatrics. And then we did a multi-site randomized clinical trial to look at the efficacy of choices. Again, it was in these different settings across the country. It did well. It's a 4-session intervention, again, tailored to meet each woman at her level of readiness, designed for delivery in healthcare settings, addiction treatment settings, correctional facilities in this case. It's in a lot of other settings now, and we use, again, motivational interviewing skills. So this is kind of the 4-session intervention. And the birth control visit is something that we have been able to arrange, and when we work with people and teach them about choices, of course, one thing that's necessary is that they either can get the woman to a birth control counseling center, counseling session, or ideally be able to provide birth control. We worked initially with Planned Parenthood here. I got a call from this, I don't even go into that. Got a call from the CDC a couple of years ago that said, are you still working with Planned Parenthood? Because if you are, we're going to pull your funding, but we're not going to go through there. We won't talk about that. But anyway, so our outcomes were 69% of the intervention women reduced the risk for being at risk for alcohol-exposed pregnancy, and 15% more women in the intervention group were at reduced risk than the control group. So these are results that you like to see. And it was kind of surprising because a lot of the women in the control group changed their behavior as well. But we obviously had some, we had a nice effect size, and what was happening in order to reduce your risk. Of course, if you're going to continue drinking, but you adopt effective contraception. We used timeline follow-back. We did a lot of really rigorous research. Anyway, so 47% of them did both reduce their drinking and used effective contraception. We got the CDC Shepherd Award for scientific excellence, and I'm really proud of that. So I don't mind saying it. It's rare for a behavioral study to get one of their awards. After that, so the whole piece now, what do? We're trying to implement choices. There have been some national and international efforts. We're currently doing a study. Danielle Parrish is involved with this study here in the Harris County Hospital District in 11 of the primary care clinics, because the CDC said, well, this is effective with alcohol. Can we bundle in smoking? So that's our, what we call the Choices Plus study. Danielle is doing a study now called Choices Teen, and you can ask her about Rush Limbaugh. He got a hold of the idea that, so Danielle took the choices intervention, we boiled it down, by the way, to a 2-session intervention. Danielle took choices and adapted it for teens in the juvenile justice setting, and that's what Laura Benjamin is working with her on that. I won't give a lot of detail, but the medical, the fellows go over to the setting and work with the young women. They don't provide contraception, but these are women 13, girls 14 to 17. And she added an HIV risk reduction component. So it's just, yeah, it's great work. So in terms of accomplishments, we have some sustainability tools. There is some evidence that it's an effective program. The CDC has developed, we wrote the treatment manual, but they've published it. There's a facilitator guide. There's all kinds of, there's DVDs, or what do you call CD-ROMs with the videos on it. It's all available free. And I don't know about the communication initiative is not my job, it's theirs. But this slide I just got from my program officer. It's hot off the press. So this is not in your packet, just this particular slide. So if you want it, get it free, you can just download it or upload it or whatever you do. But all of these materials are available, again, free. So in terms of the disseminability piece, the stuff is there. So then what happens, really quickly, what are the implementation issues that we've run into with choices? Well, immediately, people, in the real world, Johns Hopkins started using it in their STI clinics, HIV clinics across Maryland. SAMHSA adopted it, the FASD Center for Excellence adopted it, funded some projects. You guys did some evaluation of that, funded a lot of substance abuse treatment programs across the state of Texas. Immediately, we ran into FASD prevention funded by SAMHSA, run by Northrop Grumman, who is a defense contractor. I don't know about that one, but I don't know anyway, that's who has that big contract. But immediately, the treatment centers are calling and saying, so I chaired the FASD task force for the state of Texas for about 5 years. So I got to be on these calls. So the people were, really on the ground in these clinics, and they're saying, can we do choices with women who don't meet the criteria? What if they're pregnant? What if they're planning to get pregnant? What if we suspect risk drinking? What if she says she's not fertile, right? She can't get pregnant. In these clinics, it's often because they've been using drugs, and so women don't have periods, they're infertile, but once they start getting healthy, they can get pregnant again, but it's really hard to convince her when she hasn't, been able to get pregnant for a while that she possibly could. What about women who are prenatally exposed exposed to alcohol themselves? What if they suspect they had FASD, or what if they do? Or what if they have children, which happen very often once they start learning about FASD? Well, I drank during my first pregnancy. So how do you handle that well? What about women who are using other drugs? What if we can't provide birth control visits? What about choices in groups? That's a huge one, and I am a strong proponent of groups. Okay, 2 minutes, okay. Really fast here. Can we do a briefer model? So we're testing the two-session model, but this has really, I don't know if anyone else has heard of choices here in Houston. It has really sort of, really sort of taken off nationwide. A lot of people are working toward implementing it. So I love this discussions about implementation. And we have stood fast. I've gotten up and walked out of CDC meetings. I've made the public health officer in his uniform march down the hall to apologize. I mean, it's been a battle because the dissemination piece, we worked too hard to have them just, now put it out there with no training, no coaching. And so there's a master training model. We just did a big train the trainers for Denver Health. We trained 12 more people in a very careful train the trainer model. Not ideal, it's never ideal, but what are some areas, how can we compromise, what are the core components, or what are the things that really need to stay in? Lots of people are currently using the two-session model. When I was at Denver, we talked about, so we did the train the trainer model. For 2 days, the 3 master trainers went in, and we call us master trainers, which is kind of obnoxious, but Melissa Bell, Karen Ingersoll, and I went in. We trained 12 people who were very familiar with choices. Then we did straight and teach back. They brought in the community, about 30 people. They did 2 days of training where we observed them. So the woman, at one point I gave her gentle coaching about women motivation learning. We try to ask the client about, we do a little introduction. We say, I'm not going to try to change you. If there's any changing to be done, it's up to you. And this woman said, oh, I would never do that. I would never do that. I do choices in 5 minutes. All choices in 5 minutes. And I would never tell the client, I'm not trying to change you, because you know what, if I do, the client's going to say, I think she's trying to change me. So, that's the thing. You take a 4-session intervention, boil it down to 2, boil it down to 1, boil it down to 5 minutes. It's not choices anymore, but, is it better than her not doing anything with these women? Hard to say. Okay, so I think I'm sort of done here anyway in my slides. Just went blank. But sort of, just quickly, what are the considerations, obviously, in the settings? When should we consider making modifications? It depends on staffing, space. We've done choices. I think it was McLean who did it in a storage closet. Time, availability of the contraceptive visits, client considerations, which should be ahead of any other considerations. Again, does she have transportation, childcare? Is she there for 10 minutes, or will she be there for, will she be able to even come back? Why is she here in the first place? Is she here because she has a headache, or is she jailed? Jail women love for us to do this. They have all the time in the world. And then clinical considerations. What's the severity? Are there coexisting disorders, presence of other drugs, and readiness to change? And then the last 2 slides, I won't go over them, but I put them in here just so that you can see the components of choices, which are the main components and the most important components. We know some things about that, but not everything. There is to know, certainly.